Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Today, our guest is Dr. Joerg Ermann. He is a rheumatologist at Brigham and Women's Hospital and assistant professor of medicine at Harvard Medical School in Boston. He's a native of Germany and received his MD from the University of Leipzig. After a postdoctoral fellowship in immunology at Stanford University and internal medicine residency at the University of Tennessee, Memphis, he completed his subspecialty training in rheumatology at Brigham and Women's Hospital. His laboratory investigates disease mechanisms relevant to spondyloarthritis using mouse models and translational research approaches. He is the chair of Spartan, Spondyloarthritis Research and Treatment Network, an organization of North American rheumatologists dedicated to research and education in the field of spondyloarthritis. So, Dr. Ermann, thank you for joining us today to talk about biologics and biosimilars. How are you?
Good. Hello. I'm looking forward to this discussion.
Okay, so as we get started, I do have a question for you. Can you tell us what translational research is? Because I think this is something that our listeners would be interested, because I think it's a lot of what we talk about on the podcast, and I don't think we've ever framed it that way.
There's no easy answer to this. I would say that translational research is the research between basic science, which happens in petri dishes and in animals, and on the other end of the spectrum, clinical research that is solely focused on studying patients with a condition or testing drugs in clinical trials. So translational is all of that in between that involves analyzing samples from patients and connecting the knowledge that we gain in sort of the basic research setting to the disease presentations and the clinical symptoms that patients have.
Awesome. So as we get into biologics, thanks for that. As we get into biologics, we'll start there first. What is a biologic, and how do they work in the treatment of spondyloarthritis?
So biologics is a class of medications that is defined by their structure. So most traditional drugs that we use are small molecules. They have a chemical formula that you can write down on paper. And these small molecules are typically synthesized in a cell-free system. And then they can be administered as tablets, and they're taken up by the body through the GI tract. In contrast, biologics are large biological molecules, proteins. So they are a sequence of amino acids that fold in a certain way, and these biological molecules are produced in bioreactors using cell lines, and so these molecules then cannot be administered through the GI tract because they would be digested by our digestive tract. So they have to be given parenterally, that's the technical term, so as injections, either subcutaneously or intravenously.
That covers a little bit about how they're different from other treatment options, but in general, how are they different from an NSAID or a DMARD type of treatment option?
So because there are these large molecules, they cannot go into cells. So they typically work by blocking mediators that transmit signals between cells, because these large molecules remain outside of cells. In contrast, other drugs, such as NSAIDs, for instance, they as I already said, they can be taken up through the GI tract into the bloodstream. Then they can enter from the bloodstream into this space between cells in the tissues, and then they enter the cells and they act inside of cells, whereas the biologics cannot do that, and so they function outside of cells. They are typically monoclonal antibodies. So these are molecules that play an important role in immune defenses, but they're specifically designed to bind either soluble mediators or receptors on the surface of target cells, and so they can very specifically block the function of these soluble mediators, or they can block receptors, or they can have a number of other effector functions. But they, as I said, they act outside of cells typically.
Okay, so in terms of the biologics, is there a variety of different types, and what are those different types?
So it's an interesting question. One can approach this, either structurally or functionally. So structurally, most biologics are monoclonal antibodies. So these are molecules that specifically inhibit, bind to certain targets and then inhibit their function. Some biologics that we use are also recombinant proteins. So for instance, etanercept, which we use to block TNF, is not a monoclonal antibody. It's a recombinant TNF receptor that is then specifically engineered to also capture and bind TNF outside of cells. Another way of looking at biologics is functionally. So the question is, what is the target of these inhibitors? And so in spondyloarthritis, for instance, the relevant targets are TNF, interleukin 17A, then for peripheral arthritis also IL-12 and IL-23. And so the biologics differ in what kind of mediators they inhibit.
Interesting. And when you're seeing patients, first, how important is it for you to intervene or work with the patient to intervene with biologics in managing spondyloarthritis? And are there benefits to intervening early with that as a treatment?
So, it's important, I think, to emphasize that the development of these biologics really has revolutionized the treatment of not just spondyloarthritis, but of rheumatic diseases in general, and the treatment of many diseases beyond that. The reason for that is that with these biologics, we have the ability to very specifically and very effectively block specific mediators that play a role in the disease process. That before the biologics, before the development of the technology to generate these monoclonal antibodies, that was not possible. And so that was really a revolution, and rheumatology, including the field of spondyloarthritis, has sort of paved the way for a whole wave of drugs that are being introduced in many areas of medicine these days.
And when you're beginning, sorry, go ahead.
Yeah, no. So I have to, as a bracket now. What was your question? I got a little sidetracked here.
Oh no, that's okay. It was, is there a benefit to early intervention with a biologic versus trying to wait it out and use other medications?
Yeah. So we have the ability to interfere at very specific aspects of the disease process. And what we've learned now is that yes, it is beneficial to stop the inflammation early. Non-steroidals, were discovered as treatments for spondyloarthritis in the mid-20th century, and our understanding of the disease process at that point was very narrow. And so we've learned more about the mediators that play a role, and we understand, or we know at least some of them, including TNF and IL-17A. And so with the biologics, we can inhibit these molecules, and that translates into benefits for patients, because inhibiting inflammation results in reduced symptoms. And we've learned, and studies have shown this, that intervening with this disease process early ultimately results in better outcomes.
Awesome. So as you're treating someone, are there determining factors, symptom related or other, that would cause you to choose one biologic over another? And I know you talked a little bit about it, but I think with that, like, is there comorbidities that you have to consider?
Yeah. So if we, for instance, think about axial spondyloarthritis or ankylosing spondylitis, we have two types of biologics that are available that have been shown to be efficacious in treating the symptoms of the disease. And so these are the TNF inhibitors and the IL-17A inhibitors. There was only one study so far that actually compared these two different mechanisms against each other, and that study did not show a difference in terms of how effective they were. So that means that we have a number of options, because within these two classes we also have different drugs that are approved. So there are 5 different TNF inhibitors and 2 IL-17A inhibitors that are currently approved for the treatment of spondyloarthritis in the US. Just starting with this, there is no difference really in terms of what to choose, because they work equally well. And we, at least when you look at the effect of these medications in large cohorts of patients in clinical trials, it's not always the case for individual patients, but we have no parameters that would help us to identify which drug works the best for the individual patient. There are a few additional factors that play a role, though. So, for instance, we know that IL-17A inhibitors work better for the treatment of psoriasis. So, if a patient has, in addition to inflammation in the spine and peripheral joints, so if there's a lot of psoriasis, then an IL-17A inhibitor would be better. On the other hand, we know that TNF monoclonal antibodies work better for uveitis, and the anti-TNF antibodies also work for inflammatory bowel disease, whereas the IL-17A inhibitors don't. So that's an important distinguishing factor. So are there additional disease manifestations or comorbidities present that could then help to decide which of these medications should be selected. And there's another factor that plays an important role here, and that is also insurance. So the different insurance companies and plans have formularies, and they differ tremendously between the different plans, and so that also has an important impact on what treatment options are available for the individual patient.
Okay, so now if you're on a biologic or thinking about one, side effects always come up as a discussion point. What are potential side effects of biologic, and how does that get managed, or do you move someone off the biologic?
So we use these biologics because they inhibit mediators that play a role in inflammation. But the purpose of these mediators is not to make us sick, but we as human beings have these mediators to help us to defend our body against microorganisms. And so that means that if we interfere with these pathways, there is an increased risk for infections that's inherent to the biology of these biologics. But it depends on which mediator is targeted, what the spectrum of infections is that one can expect. For instance, in TNF inhibitor, or with TNF inhibitors, there's in particular risk for mycobacterial infections. That's why, for instance, we check everyone for latent TB infections before starting these medications. The IL-17A inhibitors play an important, or IL-17A, let's say that, plays an important role in defenses against fungi. So treatment with an IL-17A blocker then increases the risk for developing a fungal disease, in particular Candida infections. So oral thrush, for instance, which is a Candida infection of the mouth, is something that's more common with this type of biologic.
And thank you for that, because I know it can be tough as you're going down this path as a patient. In terms of patient populations, is there anyone that is not recommended to be on biologics?
That's a very general question. I don't think at this general level that there is anyone that I would a priori exclude from considering a biologic. Okay,
including pregnancy?
Well, that's a good question. Obviously there's always a big concern what the impact of new medications is on during pregnancy, on the mother, on the developing child. We have had the TNF inhibitors now for about 20 years, and the experience with these medications now is that they seem to be safe. TNF inhibitors can be continued during pregnancy. The other biologics, and now I want to be specific, and talk about the biologics that we use to treat spondyloarthritis, are likely safe, but we would prefer not to treat a pregnant woman at this point in time, simply because we don't have enough data. But based on the mechanism of action, I would not expect any side effects during pregnancy.
Okay, that's good news, but check with your rheumatologist and OBGYN.
Yeah, I think that's very important.
Okay, great. So once someone has started down the road of a biologic, I know they vary in the loading doses and getting them into people's systems, but are there checkpoints when you try to determine if it's effective? And are there certain criteria that you would decide it's effective or not effective, or time to move on?
So in clinical trials, the readout is typically after 12 or 16 weeks. And so that's the time that I give a medication in clinical practice. So after 3 months or so, I asked the patient to come back, and then we assess whether the intervention is effective or not. Typically, patients experience, if the medication works, they experience improvement much earlier than this. That can be a few days, but certainly within a month or so, we see improvement if the medication works.
And is it usually the patient saying they feel better? Is the guiding?
Hopefully it is that.
Yeah.
But there are more sophisticated ways for assessing this. There is a couple of disease activity scores that can be used to measure the symptom severity, and therefore also the impact of treatments. There's the BASDAI, the Bath Ankylosing Spondylitis Disease Activity Index, which is a 6-question questionnaire, which then gets calculated. The answers to these questions get calculated into a score between 0 and 10, and that is something that we use. A newer and slightly more sophisticated score is the ASDAS, and the Ankylosing Spondylitis Disease Activity Score, that is based on also a few questions plus a CRP measurement. So CRP is a commonly used blood marker of inflammation. And so the answers to these questions and the CRP value then are entered into a formula, and that also gives a number, and then can use that to measure symptom severity. So these are things that are helpful, but ultimately the most important thing is really what the symptoms are. So if a medication works, it should be something that is noticeable in everyday life. So the question of
Right.
Are you feeling better than 3 months ago should be answered with a clear yes if the medication works.
Yeah. So in terms of once symptoms are under control and people are feeling better, most biologics are typically long-term treatment. Is that correct?
Yeah, that's correct.
Okay. And in the case that someone is having less response to it, to the biologic, is it okay to switch and go back and forth? If say you take one and it's not working so great anymore and you switch to another biologic, can you go back to where you came from?
Well, so there's a number of scenarios that one can encounter here. One scenario is that we start a biologic, and then after a certain period of time, we look at the response, and there hasn't really been any improvement. So in this situation, then it doesn't make sense to continue with that medication, and we can then switch to an alternative biologic and see whether there's a better response. Obviously, there needs to be a discussion about what are potential reasons why the medication doesn't work, and that includes also some considerations about, is the diagnosis correct? An alternative scenario would be that the biologic has actually worked, and then after a certain period of time, that can be a year, it can be several years, it doesn't work as well anymore. So that we call a secondary failure. So the first scenario was a primary failure of the medication. This is now a secondary failure. And so in the secondary failure can happen, for instance, if the immune system starts to develop antibodies against the drug that then inactivate the biologic. And so in that situation, then we would switch to an alternative medication, an alternative biologic of the same class, and then often then restores the response and the symptoms decline again. And so these are sort of the two basic scenarios for how we look at the response of biologics. Obviously, there's also situations where the response is there, but there is fluctuation of symptom severity over time because there's a temporary flare-up of symptoms, which may require taking some additional medications like nonsteroidals for a certain period of time, and then after a couple of weeks or so, symptoms return to baseline. So that's also a possible scenario.
Okay, great. That was super helpful. SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie.
Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.